Okay, so we'll begin larynx. And let's look at the skeleton of the larynx. The skeleton is cartilaginous, and though we often include the hyoid bone whenever we're talking of the larynx, it truly is not part of the larynx itself. The larynx is all cartilaginous, but the reason we include the hyoid bone is there are membranes or ligaments which connect some of the cartilages or one of the cartilages, the thyroid, to the hyoid bone, which you can see here. So you can see this fibrous connective tissue. This is called the thyrohyoid ligament because it's going from the thyroid to the hyoid bone. But otherwise, the skeleton of the larynx is cartilaginous. In this, most of the cartilages are hyaline in nature. The one main elastic cartilage is epiglottis. The way you will remember it is E, epiglottis for elastic. And you also have smaller cartilages which are known as cuneiform and corniculate. And often one or the other's tips are elastic in nature too. So, okay. So let's look at this. And so this is a really magnified image of the larynx. So here you're looking at the larynx from in front. So this is the anterior view of the larynx. This is the lateral view of the larynx. And this is the posterior view of the larynx. So anteriorly, when you look at the larynx, you can see this shield-shaped cartilage, hyaline in nature. This is the thyroid cartilage. It's got this kind of prominent V which you see. And this area in men becomes really prominent and is known as the laryngeal prominence. So this area here is called the laryngeal prominence or Adam's apple. Adam's apple, and after puberty this becomes very prominent in men, boys and men. So laryngeal prominence. And below that, so I'm going to erase this, and below that you have this cartilage which you can see in front, which is called the cricoid cartilage. Now this thyroid cartilage is not a complete cartilage. That means it doesn't go all around the larynx. So you can see it in front, which you can see here. These are known as the lamina of the thyroid. When you look at it from the side, so you can see one side of the larynx and then the other part is on that side, right? And this is where it finishes over here. So this is the posterior border of it. When you look at it posteriorly, can you see it's missing at this part? Okay, so it's kind of a shield just in the front and the sides. So it's not going all the way around the larynx. So here you can see this is the side and then up there will be the front. Here it's kind of not there. The cricoid cartilage, on the other hand, is a ring-shaped cartilage which goes completely around the larynx. And we often call it as, we say it is signet-shaped, like a signet ring. And a signet ring, if you look, this is what a signet ring will look like, broader on one end and narrower on the other. So, well, that doesn't look too... So, narrower here and broader. Can you see it's narrow at one point and it gets broader like that? So, that's like a signet ring. So, if you observe this cricoid cartilage, narrow here, and you look on the sides, so it's beginning to get broader. And here, so here it's narrow, and you're looking on the side, so you can see how it's getting broader. And you come posteriorly, this here is really broad. Can you see this posterior part is the broadest, the anterior part is the narrowest here, and then laterally it's kind of increasing in height. Okay, so it's a complete ring all around the larynx. It is connected to the thyroid again by, you can see this membrane or fibrous tissue, which is called the cricothyroid ligament. So this here is known as the cricothyroid ligament. So this here is the cricothyroid ligament. You can actually feel it if you put your hand on your thyroid cartilage and take it all the way down the front. And you'll kind of feel a dip at that point, and then is the cricoid cartilage. This is the area sometimes in an emergency where you want, if the airway is blocked and you want to make sure that the person is able to breathe, you kind of can put a wide bore needle through the cricothyroid ligament right in the center, and make sure then the airway becomes patent again. And then below the cricoid you can see these are the tracheal rings. What you can also see here is a small bit of the epiglottis which is peeping out here. This is the epiglottis. There's a little bit of the epiglottis which is peeping out from in front. You can see a little bit of the epiglottis on the lateral aspect as well. And then when you look posteriorly, here's where you see the epiglottis. You see all of the epiglottis, because this epiglottis is actually and if I draw it and dot it, it's lying posteriorly like that. It's attached to the posterior aspect of the thyroid by a ligament called the thyroepiglottic ligament. So it's kind of attached like that. So that's why you can only see it. If I removed all of this, then I would be able to see the epiglottis. So now posteriorly I can see the epiglottis. So it's a leaf-shaped cartilage. It looks like a leaf. So leaf-shaped cartilage. And you can see it kind of is, this part here is the inlet of the larynx. This area here is the inlet of the larynx. So you can see it's right in front of the inlet of the larynx. It kind of closes down like a lid. On the posterior aspect, sitting on top of the cricoid cartilage, you see these two pyramidal cartilages. These are known as the arytenoid cartilages. So this is paired. The arytenoid are two of them. The cricoid, the thyroid, and the epiglottis are unpaired cartilages. The arytenoid is paired. And then on top of the arytenoid, you have those two, again, paired corniculate and cuneiform on either side. They sort of sit on top like this. And there's a little fold which connects the epiglottis to the arytenoid. And you can see that fold here. See this fold connecting the epiglottis to the arytenoid? It's called the aryepiglottic fold. I mean, you don't need to go into that much detail, but just to show you. And these little cartilages actually are present in that fold, so they make that fold a little stiff, so that it doesn't act floppy. And here you can see epiglottis is elastic, thyroid, cricoid, arytenoid are hyaline in nature. You should know which ones are paired, which ones are unpaired. Let's look a little bit at the epiglottis and look at its function also.
Swallowing occurs in two stages, the oropharyngeal and esophageal stages.
I want you to look at the epiglottis.
The food bolus is voluntarily pressed by the tongue up against the roof of the mouth and backwards towards the pharynx. In response to activation of pharyngeal pressure receptors, the swallowing center in the medulla initiates reflexes that prevent food entry into respiratory passageways. The uvula contracts, which blocks the nasal passages from the pharynx. The laryngeal muscles contract, closing the glottis at the top of the trachea by tightly aligning the vocal folds. The epiglottis swings down upon the closed glottis.
So here, can you see how the epiglottis closed down like a lid? So it prevents the bolus of food from entering into the larynx. Okay, so that's its function. The rest of it is all about digestion, so we won't look at that. Now here you can see a transverse section, a sagittal section of the larynx. So, one of the lamina of the thyroid has been removed. So you can see here is the front or anterior aspect of the thyroid, and that there is the side. This is the hyoid bone. Here you can see the cricoid cartilage, the arytenoid sitting on top, and then these are those little corniculate and cuneiform. And here, can you see the epiglottis it's attached to the thyroid posteriorly, and then you can see here, this is the cartilage, and it's covered by mucous membrane, okay? And all of these cartilages, so here when you look, this is kind of about the size, so all of these cartilages are covered by mucous membrane on the inside. And then on the outside, you can see that they have muscles, and these are what are called intrinsic laryngeal muscles. And these muscles are what will help to either close the inlet. So, what it will do is there's a muscle which will pull this epiglottis down like this, apart from the bolus acting on it. These muscles will also help to move the vocal cords, which you will see. It will help to move the vocal cords apart or bring them together, okay, causing abduction or adduction of the vocal cords. And of these, there's a very important muscle which is called the posterior cricoarytenoid muscle. Because when the vocal cords, and which we'll see in another image, the vocal cords, they come close to each other like this. This is known as adduction of the vocal cords. So the space between them narrows and less air will pass through to go down into the trachea. There are many muscles which can cause adduction of the vocal cords. However, this movement where the vocal cords are moved apart is known as abduction of the vocal cords. And this posterior cricoarytenoid is actually the only abductor of the vocal cords. It's often called a life-saving muscle. So if it is paralyzed, then the vocal cords will kind of automatically come close to each other, be floppy, and it'll be difficult. Breathing could become a problem. Now, what I want you to also notice in this picture, as I said, this was a sagittal view through the larynx. So you can see the epiglottis, you're looking at the thyroid, you're looking at the cricoid, and sitting on top of the cricoid is this arytenoid cartilage. From the arytenoid cartilage and going all the way up to the thyroid, so arytenoid posteriorly and going anteriorly to the thyroid, you have kind of two fibrous tissue membranes which go across, and these are covered by mucous membrane. So just the fibrous tissue is known as the ligament, and when it's covered by mucous membrane, we call it a fold, okay? So this on top is known as the vestibular ligament. When it's covered by mucous membrane, we call it the vestibular fold, or also called the false vocal cord. Here, this lower one, the inferior one, is called the vocal ligament. And when it is covered by mucous membrane, the same pink mucous membrane will actually cover both. Then it's known as the vocal fold, or also called the true vocal cords. So this is of one side. So you can imagine there'll be another one on this side. So this is of the left side, there'll be another one on the right side, okay? So the area between the two vocal folds is the narrowest part of the larynx, and that part is known as the glottis. So the area between the other vocal fold, which will be of this side here, so the other one will be this side, this space between the two vocal cords or vocal folds is called the glottis, and is the narrowest part of the larynx. So you can understand, if the vocal cords are abducted, the space will be bigger, right? If they are adducted, the space will be much narrower. And here you can also see that this vestibular fold, or what is known as the false vocal fold, is superior to the true vocal fold. So let's answer this question. Okay, few more. Very good. Yes, epiglottis. So we are looking at the laryngeal folds from the top. Remember, the other picture I showed you was from the sagittal section. So now if I look at it from the top, here you can see the two vocal folds. The right and the left, these are known as true vocal cords. These are very pearly white in appearance. They have very, very little blood supply, so that's why they look very pearly white. And these are inferior. And superior to them and further away, can you see these? These are further away. These are the vestibular folds, are also known as false vocal cords. And it's a good thing that these vestibular folds are further away, because if they were closer to each other, what would happen? They would block the passage of air, right? So you want them to be further away, because when air passes from your nasal cavity, from your pharynx, and it's coming into the larynx. This is the epiglottis. It will come down this way. So it will pass between the vestibular folds here, and then it will pass through the vocal folds and go down into the trachea. Got it? So you want the vestibular folds to be further away because you don't want them to block the vocal folds. In fact, remember I said the glottis, which was the space between the two vocal folds, is the narrowest part. So in this picture, you can see this is in a state of adduction. When the glottis is closed, this is in a state of abduction, and you can actually see the tracheal rings. Can you see that? Now what happens is the pitch of the voice is determined when air flows from below. So when you actually talk and make sound, the air is coming from below. It causes these vocal cords to move away. They vibrate, and that vibration of the vocal cords produces the pitch. You get that? So the faster they vibrate, the higher the pitch. The slower they vibrate, the lower the pitch. Okay? Women tend to have a higher pitched voice, and men tend to have a lower pitched voice. Now, because of this position, also I want to tell you this position of this vestibular folds being very far away. Remember we did when we were doing allergies, and we talked of when we were talking about hypersensitivity. When someone has a severe allergic response, I mentioned it could end up in something known as anaphylaxis, right? I mentioned that. So in anaphylaxis, which is a very severe allergic response, this might lead to something called angioneurotic edema. Can you see that? So this might lead to something known as angioneurotic edema, where actually what happens in such a severe hypersensitive reaction, these vestibular folds, because they are very loose and lax, they can get really swollen. So when they get swollen, can you understand? They can actually become so swollen that they will come like this now. They will lie really very, very close to each other. So what will they do? They will block the airway, right? And air cannot go in. So that's how when people have a severe anaphylactic reaction, they are not able to breathe. One of the reasons is this. The other, of course, is that the bronchial muscles also constrict. So you have bronchospasm too. So here, let's look at these laryngeal folds when someone does a bronchoscopy and looks inside, and you'll be able to see when someone makes a sound, the vocal cords move away. In fact, when someone whispers, actually, the vocal cords don't move away as much. They move away only slightly, but they still tend to whisper. And that's why your sound production, the loud, it's not as loud as it is when you talk normally, because they move far away and there's more air coming out.
Hello!
See, look.
I haven't had visitors in so long.
Can you see them?
Where are you? I'm a voice box.
See, that's
Some people call me a larynx. See my two vocal cords moving apart and together as I talk? They come apart so that the air can get through them, and they come together to vibrate and make sound as I exhale. Let me show you.
So you saw, you can see how small it is. So the pictures we were looking at were really enlarged. So this is what angioneurotic edema does. And then now from the larynx, we move on to the trachea. So at the lower border of the cricoid cartilage, the trachea begins. The hyaline cartilage now, instead of being a single piece of hyaline cartilage, it actually gets broken up into C-shaped bits of cartilage. So they're not perfect C's, but you can see, they kind of lie in one below the other. So, you can see here. On the posterior aspect, there is no cartilage. Instead, there is a muscle. So if you're looking up here at a cross section, notice here. So this is the anterior aspect. So up here, this part is the anterior aspect. And this here is the posterior aspect. And this here is the posterior aspect of the trachea. And notice there's this muscle here which is called the trachealis muscle. and see what is lying behind the trachealis muscle. See which structure is lying behind the trachealis muscle. So this trachea is about 11 centimeters long. A little bit, there could be a bit of a range there. It comes down in the neck and into the thorax, and at the level of the sternal angle, this trachea bifurcates into two bronchi. These are known as primary bronchi. Look at these cartilages. If you look at these cartilages, they are kind of C-shaped, but when you come to the area of the carina, which is this area here, this cartilage is much larger. I often say, to me, it looks like a diaper. So if you look, if I was to kind of draw it for you, can you see this? It kind of looks like a diaper. Like that, right? So this is at the bifurcation of the trachea. So this is called the carina. And if you actually look into the trachea inside, you can see a kind of fold inside, which tells you that, okay, this right and the left bronchus have started now. Okay, you can see two openings. So it first bifurcates into what are two primary bronchi. The first bronchus is called the primary bronchus. So there is a right primary bronchus and a left primary bronchus. And look at this right primary bronchus. You can see it is much shorter than the left. Look at the left, much longer. You also notice the right is kind of more in line with the trachea. Can you see that? It's more in line. The left is a little bit more oblique or horizontal. And the right primary bronchus is also of a larger diameter compared to the left. Okay, so if we put these three things together, on the right side, it has a larger diameter. It is shorter and more in line with the trachea. On the left side, it is narrower, longer, and more oblique, or some even say horizontal. Then each primary bronchus divides into what is called a secondary bronchus, or also known as secondary bronchi are also called lobar bronchi. Secondary are also known as lobar bronchi, lobar or secondary. There are three on the right and two on the left. So here, if you look at this picture here, and that's why looking at these pictures becomes really important. So here, see this, superior lobar bronchus, superior lobar bronchus, middle lobar bronchus, and there should be, it kind of doesn't show the inferior lobar, but this area here should have been labeled as the inferior lobar bronchus. The reason there are three on the right, and on the left side you can see only two, superior and inferior, because they go to the lobes of the lung. On the right side there are three lobes of the lung, on the left side there are two. That's why you have three lobar or secondary on the right and two on the left. And then each lobar bronchus divides into what are called tertiary or segmental bronchi. So these are known as tertiary or segmental. Another name for tertiary is segmental bronchi, because they go to something in the lung which is known as a bronchopulmonary segment. So these tertiary bronchi help to form something known as a bronchopulmonary segment. So that's why they are called segmental bronchi. We will take it that there are 10 on each side. There are 10 definitely on the right. On the left, authors differ. Some say 8, some say 10. Even those 8 actually do divide in the end and finally become 10. So that's why I've said there are 10 tertiary bronchi on each side, okay? And these tertiary bronchi will continue to divide and form 4th level bronchi and 5th level bronchi and keep getting smaller and smaller and smaller till they end up forming bronchioles, where the diameter is 1 millimeter. And the cartilage has gone and now there's only smooth muscle. Okay. So let's look at bronchoscopy to just see, so that you can look at the inside. Okay.
Because the right side is larger,
Yes, that's correct. That means because it's larger in diameter, more in line and shorter, if someone was to choke on something, the foreign body would lodge in the right more than on the left. Yes.
Following topical anesthesia of the airway, the fiber optic bronchoscope is introduced orally. The epiglottis is observed anteriorly.
This is the epiglottis.
The bronchoscope is then directed under the epiglottis where the laryngeal structures, including the vocal cords, are seen. The tip of the bronchoscope is advanced past the vocal cords and into the trachea. Note the anterior cartilaginous tracheal ring.
So did you see that, those tracheal rings? You can see that, how it went through. Okay, so why do you think the tracheal is present on the posterior aspect of the trachea? The word patency means to keep it open. Some of these are not working, these clickers. Okay, the correct answer is to avoid pressure on the esophagus, and that's why I told you not pressure on the sternum, because it's present posteriorly. Remember, the sternum is anterior, so it cannot be to prevent pressure on the sternum. See, that's why I told you to look at the esophagus. See this? The esophagus is lying immediately behind the trachea. Remember, the food pipe is behind the windpipe. If there was cartilage here, can you understand how it would press on the esophagus when you swallowed? You would have problems. So that's why you have muscle against muscle. Okay? Smooth muscle here, and esophagus also made of muscle. Okay, so here's an answer to your question. A foreign body is likely to enter which bronchus? Right, bronchus, yes, being more in line, wider and shorter. So here let's look at the bronchial tree. So we have these tertiary bronchi, and they continue to keep dividing. You have 4th level, 5th level, 6th, 7th, you keep going on, and then you end up where the bronchi become what are called bronchioles. And when you reach bronchioles, these are about 1 millimeter in diameter. They lose all their cartilage. There's no glands also at that level. The epithelium also becomes much lower. It's cuboidal at this point. And then this bronchiole ends up into what is called the terminal bronchiole, which is now 0.5 millimeter in diameter. So that's why we call it terminal. This is the end of the bronchiole. And this is the part where the conducting zone ends. Remember, the conducting zone was from nasal cavity to terminal bronchiole, till the bronchiole. These terminal bronchioles, so notice here, this is a terminal bronchiole. So it has smooth muscle. And this is the smooth muscle which actually is like, if you remember when you were doing blood pressure in the cardiovascular system, we talked about arteriole, and we said it was the resistance in the arteriole which was important and which determined blood pressure, right? The peripheral resistance. So same way, here it is the smooth muscle in this bronchiole in the respiratory system, which is really important because this determines whether air will pass into the alveoli or not. The other structures are much wider up there. So here, this smooth muscle can contract and cause bronchoconstriction, or the smooth muscle can relax and cause bronchodilation. So here we have the action of because it's smooth muscle, so it's the autonomic nervous system which will be acting. So sympathetic nervous system causes bronchodilation, parasympathetic system causes bronchoconstriction. So in many diseases such as asthma, you have some irritation which causes bronchoconstriction. And when somebody goes into a situation where they can't breathe properly because they have bronchoconstriction, you always want to give them a drug which acts like the sympathetic nervous system. So you give them epinephrine so that it causes bronchodilation. Okay? So here you can see, so from the terminal bronchiole, you end up in the respiratory bronchiole. It's called respiratory bronchiole because here the bronchial lumen is not complete or continuous. So if you were to look at a terminal bronchiole or any other bronchiole above that, the lumen will be complete like this, and here it will have the smooth muscle. When you look at a respiratory bronchiole, you will find the lumen is not complete because it has alveoli which bud off. And then part of the lumen here will, so here's the little bit of smooth muscle, but you can see alveoli budding off from it. And that's what this picture is showing you. And that's the reason why this belongs to the respiratory zone, because it has these alveoli and gas exchange can take place. Okay? Then here I also want you to notice, remember we saw this earlier, you saw the pulmonary arteries and the veins, and they break up into the capillaries which lie in that interalveolar septa, right? And it is here between the alveolus and these capillaries that gas exchange takes place. So it has to take place, the diffusion of gases has to take place through a membrane, right? Through walls of the alveoli and walls of the capillary. So they together form what is known as the respiratory membrane. So let's look at what will form the respiratory membrane. So imagine this is an alveolus, and let's say here's another alveolus. And this is the squamous epithelium, the type 1 cells, if you remember, right? Here, and this is its basement membrane. And let's say here is a capillary. So this is the basement membrane of the capillary, and this is the endothelium of the capillary. Remember simple squamous epithelium? So now gas has to pass from here through this, and go in here. And oxygen, so CO2 comes towards the alveolus, and oxygen from the alveolus will pass out through the same thing and go through here. So this area is what will form the respiratory membrane, right? So if you look at this, what will the respiratory membrane be made up of? It will be made up of the alveolar epithelium, which is squamous in nature. It will be made up of the capillary endothelium, which is again squamous in nature. And then the fused basement membranes of both these structures. And the fused basement membranes. So that is very, very thin, and that allows the diffusion of gases easily. Whenever there is any problem which causes congestion in these blood vessels, can you understand that fluid can go out and it can kind of lie here between the basement membranes and make it thick? So that's when respiratory problems occur, because diffusion of gases cannot occur. Or if people suffer from, you've heard of these diseases, you know, when they go and when they work in places where there's asbestos mining or coal mining, and they suffer from those kind of occupational diseases, asbestos, all that fine dust and coal, smoke and all those fine particles actually get deposited and they cause thickening of this membrane, and that's why these people have respiratory problems. Okay? So here these were the pulmonary arteries and veins which we saw, which came from the heart and took blood back to the heart, and so they were involved in gas exchange. But how about the arteries and veins which will actually bring nutrition to the bronchioles and take away, you know, the waste products? That is done by bronchial arteries and veins. So you have separate bronchial arteries and veins, so they will travel with the bronchi. So that's a bronchial artery which will carry oxygen to the nutrition to the tissues, and then you'll have a vein which will be which will take back, like everywhere else, it will take back waste products. So veins from here will go back that way. So these are bronchial vessels, arteries and veins, which are like any artery or vein out anywhere else in the body. So they are carrying nutrition to the bronchial tissue, and they are taking away the carbon dioxide and other waste products. And here, just at this picture also, you can see that there are 3 lobes on the right lung, 2 on the left. That's why you have 3 lobar bronchi on the right, or 3 secondary, and 2 secondary or lobar on the left side. Okay. So what is present in the interalveolar septae? Septum should be the correct thing here. So what is present in the interalveolar septum? So between the alveoli, in other words. Interalveolar is between the alveoli. So I just drew an image for you. a little diagram for you. Very good. Yes, pulmonary capillaries are present between them. So now let's move to the pleura. So you did pericardium. Remember, there was serous pericardium, which had a fibrous and a visceral layer. And then, of course, in the pericardium, we had an extra pericardium on the outside, which was called fibrous pericardium. Now here we have pleura, which is a serous cavity. It also has two layers. So there is this outer layer, which is known as the parietal pleura, which will be lining the inside of the thoracic cavity. So here, if you look at this picture, this is the thoracic cavity. And here, this pleura, which is here, is the parietal pleura. So can you see how it is lining the inside of the thoracic cavity? So see this, it's lining the inside of the thoracic cavity. It also goes and lines the diaphragm here. So notice this, okay? And then it will come here into the mediastinum. So here, if you look, the same thing. So it's lining the inside of the thoracic cavity. It will line the diaphragm and go up. Then it gets reflected, and then now it forms the visceral pleura, which is intimately attached to the surface of the lung. You cannot separate it from the surface of the lung. And in between the two is the pleural cavity. So like the pericardial cavity, this pleural cavity is going to surround the lung. The lung doesn't lie in the pleural cavity. The pleural cavity only has fluid in it, little bit of fluid. Okay? So the pleural cavities are separate. The two pleural cavities are separate, just as the two lungs are separate. So there's a right pleural cavity and there's a left pleural cavity. And both pleural cavities have little fluid in it so that it helps to lubricate the lungs, because when the lungs expand in volume, they fill the cavity more, and then they recoil and during expiration and go back to a much smaller volume. Then again, there's movement. So that's why it helps to allow frictionless movement of the lungs. So look at this question. Which of the following statements is false? Okay, right. Well, most of you got this right. It's the inner wall is not lined by visceral pleura. Remember, it is lined by parietal pleura. That's what I showed you here. See the inner wall or the inside of the thoracic cage. This is the inside of the thoracic cage. This is the inside of the thoracic cage. That is lined by parietal pleura. Whenever you talk about visceral pleura, you have to talk about lung, attached to the lung, okay? So, and then this, the bronchi are supplied with oxygen by bronchial vessels, the bronchial artery part of it. The sympathetic nervous system does cause bronchodilation. And again, if you looked at the previous thing here, see bronchodilation, sympathetic. So, very important to look at these PowerPoints carefully. And this, of course, pulmonary vessels are responsible for gas exchange. So this was incorrect. Had it been parietal pleura, then it would have been correct. Now here let's look at the lungs. So these are cone-shaped, and this is a really nice picture. So look up here. This is the inside of the thoracic cavity. Look at this. This is lined by parietal pleura. Look at the lung lined by visceral pleura and the pleural cavity in between. And here we can see the lungs are cone-shaped. So they have an apex and a base. The apex rises up into the neck. So you can see this is going up into the neck. The base lies on the diaphragm. Can you see that? The base lies on the diaphragm. They are related to the sternum and the costal cartilages anteriorly, the diaphragm inferiorly. They're related to, again, the ribs on the lateral side and posteriorly. And way posteriorly, you have the vertebra. Okay? So here is the apex, the base. You can see this medial border, and then you can see some sort of lines or grooves or what are known as fissures. And all of this area is related to the ribs and costal cartilages. Up here, a little bit of the sternum will be present. If you look at the right and left lung, if you compare the two lungs, the left lung is a little bit longer and narrower. The right is broader and shorter. But the left lung also has a little sort of indentation here, which is known as the cardiac notch, because the heart is present in that area. So this accommodates the presence of the heart. And just below this notch, you can see this little tongue-shaped process which is present here. This is often called the lingula. Lingual means tongue. So it's a little tongue-shaped process seen in the left lung. And that's why looking at these images is so important, because if you got a question, which part of the lung rests on the diaphragm? And just by looking at it, you can see the base of the lung is sitting on the diaphragm. The apex, it's like a triangle. So the base is always opposite the apex, and you can see here. Now, both lungs have a little oblique fissure. So this one here is called the oblique fissure. So notice the one on the left side and the one on the right side. This oblique fissure divides the lungs into an upper lobe and a lower lobe, or called superior and inferior lobe. So you can see superior and inferior lobe. And only on the right side, you also have a horizontal fissure. This is sometimes also called transverse fissure, because horizontal and transverse usually mean the same thing. So horizontal, also known as transverse fissure. And on the right side, this transverse fissure now divides the upper lobe into two parts, a superior or upper and a middle lobe. Okay? So you have an upper or superior lobe, a middle lobe, and an inferior lobe on the right, a superior and inferior on the left side. Transverse fissures only present on the right, but oblique is present in both. Now, if you look at the medial surface of the lung, which you can't see here, but that right in the middle, that area which was the mediastinum. We remember the mediastinum was the area between the two pleural cavities in the middle. So here, if you look at this medial part of the lung, this area here, this part here is known as the hilum of the lung. When we did lymph nodes, remember we talked of hilum. Hilum is just a gateway where structures enter and leave. So here, this is the hilum over here. This is the hilum of the right side, hilum of the left side. And in both lungs, three major structures enter or leave at the hilum. They are the bronchus, a pulmonary artery, and a pulmonary vein, and two pulmonary veins. So you have pulmonary veins which are anterior-most. So these are anterior-most. The artery is in between, and the bronchus is posteriorly placed. So here in this cross section, you can see really well, you can see the bronchus going in. Notice how the artery and the veins, they follow the bronchus. The reason being the bronchus goes and divides into bronchioles, which become respiratory bronchioles and finally give rise to alveoli. And that's where gas exchange has to occur. So that's why the pulmonary vessels closely follow these around. And then here you can see the visceral pleura, which actually goes into those fissures. So it will go into the oblique and transverse fissures. And then here on the outside is the parietal pleura, and in between them is the pleural cavity. So this surface, this area here, this surface is called the mediastinal surface, which is the medial surface. And in the medial surface, you have this hilum of the lung, or in the mediastinal, you have the hilum of the lung. So the hilum contains the pulmonary artery, vein, and bronchus. These are the main structures. You also have nerve plexuses, lymphatics going in, but they are not shown in this image, but you all have those too. Now, if you remember earlier, I mentioned that those tertiary or segmental bronchi, these went to areas of the lung and they've helped to form what is called bronchopulmonary segment. So if you think of it, the bronchopulmonary segment has two parts, a bronchial part and a pulmonary part. The pulmonary is the part from the lung. The bronchial is the tertiary bronchus. So how many tertiary bronchi were there? 10 in each lung, right? So each of these 10 go to a specific area of lung tissue. So together they form bronchopulmonary segments. So here you can see these bronchopulmonary segments. So naturally there are 10 bronchopulmonary segments. However many tertiary bronchi you'll have, that many bronchopulmonary segments you have. So we often say a bronchopulmonary segment is aerated by a tertiary bronchus. Aerated means this is what is bringing air to it. So it's aerated by a tertiary bronchus. So here it is. I didn't realize here. Aerated by a tertiary bronchus. It has its own pulmonary artery. So you'll have its own pulmonary artery. But the vein lies in between, intersegmental. So let's say if I was to draw this, this is the pulmonary artery going to this bronchopulmonary segment. This is a branch of the pulmonary artery going here. Here's a branch going here. The bronchus, so it has its own bronchus as well. So here's the bronchus. So I'll just draw for two of them. The veins are intersegmental, which means that the veins they don't lie inside the segment, they actually lie in between the segments. These are pulmonary veins which lie in between the segments, and then they will pass out and then they will go out. And that in a way is good for us, because whenever these bronchopulmonary segments, they are kind of pyramidal in shape with the apex towards the hilum. They're often called independent functional units of the lung, because you can remove one bronchopulmonary segment and not affect the functioning of the other areas of the lung. So you can just remove one segment and the other parts of the lung can be undisturbed. And that's because these veins, you kind of go in between the connective tissue, and veins don't bleed much, so it's easy to kind of separate these. This you can do, imagine if someone had a lung abscess in one area, you can just remove that bronchopulmonary segment and not disturb that. But in cancers, that's a little bit difficult to do, because cancers tend to spread. So they kind of spread all across. So it's not easy to do that in cancers. But otherwise, anything where you have maybe a bad tubercular segment which has a lot of cavities, or lung abscesses which need to be removed, you can actually remove a bronchopulmonary segment and not affect the functioning of the rest of the lung. Now, when lung tissue collapses, so let's say that there's some problem with one bronchopulmonary segment, or problem with the lobe of the lung, and the lung collapses, like we did when we talked of IRDS. Remember when surfactant production was less, and I mentioned this term atelectasis. So that means it is when lungs are collapsed, or when the alveoli are collapsed. So that area is known as the atelectatic part of the lung. So this is something you all will see some point in your life. So this is a normal chest x-ray. So whenever you take an x-ray, usually anything which has air in it shows up as black. Anything which has fluid or bone which is dense shows up as white. So, and any metal, so heart, the blood has iron in it, so that again shows up as white. So you can see the lungs on either side. And this is the heart over here. Here is the diaphragm. Up here you can see a little bit of the ribs. And notice usually there is these areas here, you can see they're very, very clear. And that's because there's no pleural effusion. This angle is very clear. When the pleural cavity gets filled with fluid, it's called pleural effusion. If it gets filled with air, we call it pneumothorax. Pleural effusion is when the pleural cavity is filled with more fluid than normal, filled with fluid. So here in this image, you can see in this x-ray, the angles are clear. If someone had pleural effusion, actually you will see this area as being white like that. This area would be white. So you can see on this side, the angle is clear, but then this side, you can see the angle is not clear. And often just a simple x-ray can tell you that. So here you can see this is pleural effusion and pneumothorax. So here this is a normal pleural cavity. And look at this part here. This is effusion. So this pleural cavity is now filled with more fluid than normal. So what is happening? The lung is collapsing, right? Because the pleural cavity now inside, it's got of fluid in it, and the pressure is getting positive, and it's kind of pushing the lung away from it. So the lung begins to collapse, and you obviously have to drain it. So this is how you put a needle and you drain the fluid so that the lung can re-expand. In this case, this is where there is air. Pneumothorax, as I mentioned, is when there is air in the pleural cavity. And if there is air inside, the air could be, let's say, something in the lung ruptures, or, a stab wound kind of pierces a part of the lung, so the lung is open. Every time you breathe in, air flows out and it gets in here. So here you can see this whole area is filled with air, and can you see now the lung is totally collapsed. So this is an atelectatic lung. Obviously, the air has to be removed in order for the lung to re-expand and be able to carry out its function. Because when that atelectasis happens, what happens? That side, there'll be no gas exchange, isn't it? That lung is non-functional. Okay, so let's see if alveoli are collapsed like in atelectasis, what would be affected? Very good. Yes, gas exchange, because now no gas exchange can occur at this point. So here let's look at some clinical conditions. Laryngitis, the word itis always means inflammation. So laryngitis is an inflammation of the larynx. So, when you sometimes begin with a sore throat, your pharynx is inflamed, that is called pharyngitis. And it can pass down into the larynx. So here it's often accompanied by hoarseness of voice. So pharyngitis, laryngitis is where the voice becomes hoarse, you're not able to talk. So best thing is to give voice rest. I already mentioned angioneurotic edema, and this is an example of angioneurotic edema where this person's vestibular folds are beginning to swell. And imagine if they swelled even more, they will actually now come like this. And hence they would block the airway, and there'll be severe respiratory distress. Whenever anybody has any problem breathing, that is known as dyspnea. So dyspnea is difficulty in breathing. So when we say someone is severely dyspneic, that means they're having difficulty breathing. And one of the common causes of dyspnea is something known as chronic obstructive pulmonary disease. COPD stands for chronic obstructive pulmonary disease. And two conditions which fall under it are emphysema and another one called chronic bronchitis. In emphysema, what happens is the alveolar walls, they break down. So in emphysema, these are the alveoli like this. So these walls break down. So it becomes like one big bag. Okay, and even the smooth muscles go into a spasm. So what happens is it becomes very difficult for air to go in and even more difficult for air to go out. So there is an obstruction to the passage of air. So these people obviously will have difficulty breathing. In chronic bronchitis, the bronchi and the bronchioles, these are inflamed. Bronchitis means inflammation. So if this is let's take a bronchus or a bronchiole, these are inflamed, they produce mucus. So that mucus acts like a plug inside. So again, it obstructs the airway. So again, you have difficulty breathing. Okay. Pleuritis is a condition which is it's the beginning of pleural effusion. So this is just inflammation of the pleura. And when the inflammation kind of proceeds, usually starts with a lot of pain. And then any inflamed membrane will always secrete. So when it secretes a lot of fluid, it causes an effusion. that can build up quite a lot. And then I said pneumothorax is a condition where any stab wound which kind of punctures the lung, opens up the pleural cavity, or sometimes someone with emphysema, when they have a little, what are called like little bullae, these are like blisters on the surface of the lung, that ruptures. Then from there also air from inside the lung can go out into the pleural cavity and cause pneumothorax. So again, the pneumothorax, air keeps filling in, it can become a medical emergency, so you have to remove the air promptly. And then I told you atelectasis is a condition where there is collapse of the alveoli or of the lung. It can involve just a few alveoli, it can involve a whole lobe, or it can involve the entire lung. Okay, so we are done with this.